group of speakers is Dr. Jackqueline Cooper and her troupe. And Dr. Cooper, I'll just tell you about Dr. Cooper. She graduated from Tarleton State and Stephenville with a degree in social work. I have a cousin who wants to be a social worker, so I'm interested to see how successful you can be as a social worker. She had her master's of healthcare administration at Webster University in Fort Sam, and then she got her doctorate of industrial organization psychology, so she knows what you're thinking out there. And she's spent her time working for a company called GIA Management, which represents 25 Medicare insurance companies. She also works for a nonprofit organization called Tri-HM Foundation, which administers a large number of nonprofit nonprofit organizations. And she's going to talk to us today about Medicaid and how it works and how you can get your patients taken care of through this system. Jackie? I'm going to pull you up here, right? There we go. Okay. Thank you.
Thank you. Sure, I don't hit anything. Good morning, everyone. How are y'all? Today when I came in, I used my smartphone because I didn't know where I was going. I knew the vicinity, but I didn't know exactly where I was going. And that's the same with Medicaid. I'm sure all of you have heard of Medicaid, and you think you know Medicaid. Anybody not heard about Medicaid? Okay, all right, see? So today it is to talk to you about Medicaid, what you really don't know that can hurt you. With all of you, you've heard about Obamacare, Medicaid and Medicare. I don't know if you've heard about all the mergers that have gone on with all the different insurance companies, and you literally need a GPS to know, one, which plan your client is on, and two, how to make money. So today, what I wanted to talk to you about is that you have choices. Some of you have heard that it's best not to take Medicaid. Some have said, you know, want to opt out of doing Medicare and just do private pay. So today I just want to tell you about Medicaid and why you're needed in that insurance. Unfortunately, I do have to tell you about some history. And I mean, I know all of you say that you know about Medicaid, but it was established in 1965. It provides medical insurance, well, he gave me this. It provides medical health coverage for low-income individuals and families who fit into an eligibility group that is recognized by the state and federal law. You can be a part of this with age, whether you're pregnant, disabled, blind, or aged again. Income resources like bank accounts can be used, and also if you are lawfully admitted immigrant, you can be on Medicaid. Medicaid covers the health care, doctor visits, hospitalization, and medication. You can also use it for DME, and most of the time when my clients that I have, they're all considered duals. They have both Medicaid and Medicare. Unlike Medicare though, Medicaid is not all entitlement. I know you know Medicare Part A is an entitlement, right? Y'all know about Medicare Part A being the entitlement, B being enrolled. Well, with Medicaid, persons who's qualified for Medicaid based on disability and income are entitled to the basic services, meaning that there's no wait for the services. For people with disabilities and seniors, Medicaid is a major funding stream for long-term care. And so remember when Dr. Williams was talking about long-term care, Medicaid is also being used for that. And the intermediate care facilities where people live in is an entitlement for eligible individuals. So they can be as small as 6 people living in the home or as large as 600. And the one thing about that is not an entitlement is the waiver programs. And the waiver programs are the community-based services. Most of the clients here in San Antonio are on these waiver programs. Aetna, AmeriGroup, Community First Health Plan, Superior are part of that community-based plan. And the numbers right here beside there are how many people that they have in their plan as of August. Star Plus, AmeriGroup, Molina, and Superior Healthcare. So when you as a doctor are asked to be a part of these different Medicare HMOs, make sure that you sign up for the Medicaid side. Reason why? Because if you don't, your client is going to have a totally different doctor for Medicaid as their PCP than what they have for their Medicare. And so then you will not be able to see your client or get paid by Medicaid for any balance billing that needs to be done. Bexar County, which is right there, consists of Atascosa, Bandera, Bexar, Carmel, Guadalupe, Kendall, Medina, and Wilson for the Star Plus areas. Same thing for the Star Service areas, same area, and then, so then therefore you know that you're going to be seeing people from all those different counties here in San Antonio. The waiver programs are what we're talking about today, not traditional Medicaid. The traditional Medicaid is something that you already know about, but it's the waiver programs that are very interesting because we have 9 programs, which in San Antonio, most of the clients are in them, and the waiver programs also are the ones that you're going to see possibly almost every day. The children's program, those are children and young adults under the age of 21 at the risk of nursing facility placement because of the complex medical needs. HCS is the program that I do. I have 5,000 consumers in the state of Texas that I handle all of their Medicare and Medicaid. They're with the HCS program and the ICFMR programs. These are people of all ages who's qualified for institutionalized settings, and they're level 1 care. These consumers are those consumers that we used to say are part of MHMR. And those consumers have waited 10 years to get on this waiver program. It is not an easy program to get on. It is not income-based, it's need-based. And so then therefore, with those consumers, there's 46,000 consumers currently with the 11 local authorities within the state of Texas, and those are the ones that we're going to talk about today. There's the class system. The class system are for people of all ages who have qualifying disabilities other than mental retardation. It had to start before the age of 22, where they're effective for their daily function of daily living. The deaf, blind, multiple disabilities are people age 18 and older who are deaf, blind, and have a third disability that qualifies them where they should be institutionalized. The community-based alternatives is actually the program that keeps your consumer in the nursing home. Those are the programs that it only takes 30 to 45 days for them to get into that program, and if they were not in the nursing home, it would take them a total of almost 3 to 4 months. The Star Plus program is the CBA population, and they're in Travis, Bexar, Harris, and Nueces counties, and it's a part of a waiver program. San Antonio is the only one that have the consolidated waiver program, and it's for those people that are in the nursing facility. And then we have the Texas Home Living, people of all ages living with their families in their own homes who qualify to be in the nursing home, but they have to meet a certain income limit. How many times we hear that Social Security is not going to be here? We have to have the Social Security benefits in order for us to be able to have the waiver programs that we do have. Some of them are based on income, and so then we have the SSDI and the SSI. And those incomes are, usually you have to have less than $2,000 in the bank. And the monthly income is under 250% of the federal poverty level. The state of Texas started the waiver programs pretty much so that they can do two things. One was that they wanted to take care of people with specific needs and disabilities, and the other one was because of the fact of the license requirements for service providers. So often the waiver will use the individual's income, which in the case of the children is nothing. According to Kaiser, there are 3.9 million people on Medicaid. And so with that being said, here in Texas, we have a lot of Medicaid population, and unless you know about the different waiver programs and what you're able to do, it's really hard to be able to navigate through them. In 2010, the U.S. Census Bureau said that the U.S. poverty population is at 4.6 million, which 10% of those are here in the state of Texas. So there's no way around it. You're going to have to be able to do Medicaid. There's 1.9 females in the state of Texas that have Medicaid, and 1.7 males. So there's just really no way around it. You are going to have a lot of your clients that are on Medicaid. This is the part that affects me. And when I say that, it's because the waiting list to be on the Medicaid program, you think that you can just go to the Medicaid office and get on the programs, and that's not true. Those people that we used to say MHMR, but it's IDD, there is 70,000 people, 70,000 children and young adults that are on the waiting list just to be able to get on the Medicaid waiver program. Those individuals, once they've been diagnosed as having any kind of mental illness, they are put on the list down at ACOG. They have to go through a number of tests to see if they qualify, and then they have to sit there and not get services for 10 years. So those are the ones that I work with. The aged and disabled, there's 40,000 people that are on the waiver program, on the waiting list. And for children, there's 14,000 that are currently on the waiting list. I do want to tell you, every year for the IDD, they only allow 300 people off the waiting list a year. HCS only serves those with an IQ under 70. and class only serves those with developmental disabilities. So when you are working with this type of population, you have to understand that they're not going to know what you're telling them. And sometimes the caregivers are not going to know. And if they're living in a group home, you're working with people that only have maybe a high school education, so they're not going to know. So then therefore, it is very important that you understand the population that you're working with. HCS provides services with IDD. They live with their family. They live in their own homes. They live in group homes. Have y'all ever heard of Mosaic or Center for Healthcare Services, all those different facilities? Those are where they live. Some come there on a daily basis just to get their medications. Others are there and they live in the group homes. There's 21,000 consumers that are served by 450 companies. And approximately, now on this list, it says approximately 50,000 people are currently on the waiting list. And that's because some people have opted out. If they call your number and the family member that's taking care of them do not respond, after 1 month, they send a letter. 2nd month, they give your spot to someone else. So approximately 50,000 people are currently on the waiting list. For the ICF MRs, once again, that's an entitlement program. These consumers usually or always have Medicaid. They never have Medicare. So then these consumers are the ones that when you see them, that there's only 6,000 consumers and they're served by 175. Most of the time, you want your consumers to be over to HCS because HCS is the Cadillac of the waiver programs. It is just like the top. And so that's the reason why most people wait the 10 years for the HCS. I do want to tell you with that program, it is, most of those consumers, the different things that you have told, that I have looked at to see what conditions you address as urologists, a lot of my consumers have gone through those issues. They are either on Medicaid or they're Medicare. We have issues with medications. We have issues with them getting the wound care. We have issues with them getting PT that is needed. So that's the reason why it's very important that you know what services they're on and know how to help them and not just let them go. When you change insurances with this community, you changing and deciding that you don't want to take Humana anymore affects them, because then if they choose to want to stay with you, they have to maybe give up their other doctors just to stay with you. So you have to be mindful of when you make changes for your life, it affects their lives as well. The different conditions that I have up here are the very conditions that have come up in the last 3 years with these consumers. And it is these conditions the reason why I'm here today. Honestly, I'm not gonna lie, I didn't know everything that y'all do. I really don't. I mean, all I know is that it's urology and I was asked to speak. Okay, you want to know the truth? So I'm just gonna tell you, because y'all are a little bit too quiet, and I understand Medicaid is boring. It's boring, I ain't gonna lie to you. But the thing of it is that it's a necessary means here in San Antonio. Plus, I'm gonna tell you something. You know, I told you they said I went to Tarleton. I came to San Antonio so that my student loans would be forgiven because of the Medicaid population. Because as long as I did work within the healthcare arena, my student loans, my Perkins loans, were totally forgiven. I graduated in '92. I'm not going to tell you how long I waited to go to school because that's none of your business how old I am. But, you know, the thing of it is that Medicaid is necessary. We hear and we know, and I don't preach the word of God, but, you know, the poor will be with us always. They will be with us. And so we have to learn how to work with the population. And the population that I currently work with, which is the HCS and the ICF, as far as the male sexual dysfunction, because of their disease process, they know about money and they know about sex. All right? Money and sex. So then a lot of times we do have a lot of clients that have problems with male sexual dysfunction and impetus. And they will talk to me about it, you know? And all the other conditions that are outlined here in the last 3 years, probably about 60 of my clients have been in for either prostate or bladder cancer. And that's within the last couple of years. One thing about working with this clientele, you have to be comfortable with working with those that are MHMR. You have to. It's not easy. They can't communicate to you. They have, some will fight you when you come near them. You have so many other things that are going on, so you have to be comfortable. I personally became comfortable when I'm from a small town in West Texas. My mom used to work for Skyview Living Center, and I was scared of those people growing up, okay? It wasn't until I did my internship at Rock House for Tarleton State University for bachelor's in social work, that I realized that they were just like me. You know, they had the same needs, the same desires. It's just the idea that we had so much, they had a few more issues than y'all know about what I have. Y'all don't know my issues. You can see theirs, all right? One of my issues is that I'm scared stiff up here talking to y'all and nobody's smiling, okay? All right? That's an issue for me, all right? One of the other issues that I have is that it could have been me. When I work with those clients, it could have been me. And so it is so important that when you as physicians are working with the clients, that you have a great bedside manner, that you realize that these clients they might be on Medicaid, but they're still good people. Yes.
It could be any of us, to be honest.
That's it.
Disease or an accident.
That's true. That's true. And so then it's very important that everyone understands that. And even, you know what, student loans can wipe you out. And you could be on Medicaid. Does it make you any less of a person? No. So I think that my main concern is knowing that you understand and you respect the Medicaid population for who they are. The Medicaid population is the ones that's going to feed you, honestly. But it's also the Medicaid population that needs you to also go that extra mile sometimes for them, because so many people don't. So with the HCS and ICF community, you're going to have to learn about the population. You're going to have to know that you're going to work with the caregivers more than you work with the client. You have to know that you're going to have problems getting paid. Everybody hear me? You're going to have problems getting paid. All right, y'all act like that's good. That's not good for me, okay? And so, you know, because they're on these waiver programs, they have to get everything approved through the state. And then also the group home has to be willing to pay what you said that you're supposed to be paid. So it is very important that you understand. And with that being said, Nick from Essentia Home Health is one of the home health agencies that work with these consumers. They do the PT, they do the wound care, and he's going to tell you what you as a physician must do in order to get home health for your consumers and get paid.
Thank you. Good morning, everybody.
I don't know how to bring
Good morning. My name's Nicholas Brown, and I'm with Essentia Home Health, like Jackie said.
I don't know how to use his
Okay.
thing.
Well, we need to pull up my presentation, but just to let you know a little bit about myself, thank you. Our agency is a family-owned and run agency here in San Antonio for the past 6 years. As far as relating directly to urology, we do a lot of catheter care, as well as medication monitoring, labs, urological labs, as well as blood tests. So the reason that I'm up here is to help build an understanding for a system, home health, which serves a low-income people. So we do serve Medicaid and the Medicare recipients. Home health, the main objective is to keep folks out of the hospital, ER visits, and hospital stays, to keep those dollars down. And one thing to start off with, if you do receive documentation for home health in your practice, wherever you're practicing, most likely the insurance eligibility has already been verified by the home health. So if that's a concern with that documentation, it's most likely already been verified. Alrighty. And just do use the down arrow? Okay, thank you. All right, hit the down arrow. Criteria for home health. Home health, like the name says, is skilled services provided in the home. We have to pay attention when we're talking about home health, homebound status. And one of the main things that will affect you all is going to be a documentation called the face-to-face. And this is a description. That should be a brief narrative describing the patient's clinical condition and how the patient's condition supports homebound status, as well as the need for the services. Just to go over the skilled nursing services, we offer in home health observation and assessment. So we can go in and you can have a nurse reporting to you. And just to let you know, home health services can be supervised by a specialty physician, especially in the case where urological issues might be the main concern for this patient. Home health can be a tool that you can use even without being the primary care. So we can also do training and education where the nurse goes in and helps the patient or the patient caregiver more understand their disease process and their treatment and medications. Another skilled procedure, or another skilled service that home health does, is skilled procedures that require a nurse. So somebody goes home with, ostomy or catheter, wound care, that sort of thing. Home health can provide services to make sure that that procedure or that wound is covered at home and has a little bit more coverage in between just the doctor visits. Let's see. We also do physical therapy. Physical therapy consists of the therapy evaluation, the exercise program, and placing that in a home environment so that they can do those exercises someplace where it makes sense to them, with equipment that makes sense to them in the home. And also, we work with gait training, retraining muscles, and dealing with abnormalities in muscles. And also, we do deal a lot with fall risk. It's one of the major things that we look at, especially dealing with our geriatric population that we see in home health. A couple other things for physical therapy. We also deal with speech therapy in home health, and this is just a list of things that speech therapy focuses on in the home health setting. Again, a lot of evaluation, so home health can be used as an evaluation tool to get a good broader range of what's going on with the patient, like I said, other than just at that one time or the time in front of the physician actually. Add some more data to that case. Also, as you can see here, it's focused on improving what you already have going on, whether it be cognitive or communication abilities. So we went over here the services, the skilled services that home health provides. These services are eligible for those folks that are considered homebound. So homebound is a patient, is defined, the patient is homebound when there is a normal inability to leave home, and consequently leaving home requires a considerable taxing effort. Now that might not be as constricting as you might think. Absences from home are infrequent and for short periods of time, generally less than once a week for social reasons. However, things like the barbershop, walk around the block, family reunion, funeral, graduation, other unique events still qualify a person as homebound if they go to those. Also, absences from home that are related to health care are allowed without restriction. And attendance to religious services. Another thing that we don't have here is adult daycare is permissible to be considered homebound. So if the person goes to adult daycare 5 days a week, can still be considered homebound. However, the skilled services provided by homebound or by home health cannot be done in the daycare. They have to be done in the home. Some examples here are a patient who's confined to a wheelchair or another aid that in order to walk safely. So that's going to be obviously a taxing effort to get out and move around in the community. A patient with impaired vision, suffering from dementia, and requires assistance from another person to leave the residence. Somebody who has lost use of their upper extremities, unable to open doors, use handrails, stairs, and carry items while they're walking around. That's going to be considered a homebound person. A patient suffering from weakness and pain, therefore restricting, and their actions may be restricted by the physician for a specified and limited amount of time, maybe getting out of bed or other activities of daily living. So homebound status doesn't have to be permanent either. When you think about homebound status, could apply to somebody for a short amount of time, and home health can be in there in that amount of time to make it even shorter. So this is just going over different sort of conditions that a person may have that contribute to their homebound status, whether it be a heart condition and they need to avoid certain activities, whether it's long-lasting or not, their rehab or not, a patient who becomes easily short of breath, somebody with balance issues, and maybe at that time is having a hard time with ambulation on different terrains. somebody with neurological issues or degenerative diseases, psychiatric issues, even alone, kind of like the folks Jackie was talking about, you know, just having those sort of issues, even though it's not maybe physically manifested, can still result in somebody being considered homebound. And seasonal homebound, maybe due to inclement weather, somebody's more able to get out of the house depending on the conditions outside. Okay, so the third part of this, we've gone over the skilled services, the homebound criteria, and now the face-to-face document, which is, I actually do the marketing for our business and orders management, so I run into explaining this document a lot with physicians out in the community. You know, it doesn't require just a check, you know, or a box. You have to formulate an answer to questions, and sometimes, you know, this document gets put underneath the stack real quick, but it's absolutely something that it's required for these patients to get the services and for those providers to get paid. It's something that was created by the Affordable Care Act. It's a condition of payment. Prior to certifying the patient's eligibility for home health benefits, the certifying physician must document that the face-to-face encounter has occurred. This can also be filled out by non-physicians and then signed by a physician. Okay. And this went into effect January 2011. So, for a person to have home health, they need to have the face-to-face. The face-to-face requirements ensures that the orders and certification for home health services are based on a physician's current knowledge of the patient's clinical condition. So that can be relayed to the physician by a nurse practitioner or a PA or other folks of that nature, if it is also then signed by the physician as well. Okay, so that's just going over the different folks. A nurse midwife, I haven't seen that, but I guess that's an option as well. Okay, so in addition to following nurse practitioners to conduct the face-to-face encounters, Medicare also allows physicians who attend to the patient in the acute or post-operative settings, but does not follow the patient in the community to certify the need for home health and their contact with the patient to establish and sign the plan of care. The acute, post-acute physician, okay, then hand off care. So what that is basically saying is that just in the process of home health, you do need certain things. The face-to-face encounter is one of them, and also orders plan of care. But there is flexibility in what physicians are signing that plan of care and that face-to-face. It doesn't have to be the same physician signing the face-to-face as signs the plan of care. Should they coordinate with each other? Most definitely. But you know, it's thought of sometimes when I bring the face-to-face to say a rehab doctor or a specialist that's seen the patient, and you know, they're the ones that have initiated the home health, but they're not going to follow. You know, we need this particular document signed sensitive to an encounter that's happened, whether you're going to follow the plan of care or not, and that's permissible by CMS standards. So, and that basically went over everything else there. So, and also in rural communities, telehealth is allowed as a face-to-face encounter, but probably not recommended.
You skipped the slide.
Oh. Right there?
No one doctor.
Oh, right here. This is the one, right?
Yeah.
Okay.
So in the state.
Okay. So when you're dealing with the face-to-face, it can either be done on an actual form that has the questions listed and makes it a little easier, or it can just be simply a paragraph as a part of an order or an addendum to an order. So, you know, face-to-face technically could be written on a prescription pad signed by the physician, you know, as long as it includes certain statements. Also, this encounter is based off of a face-to-face time with the actual patient, and that had to have occur 90 days before home health started or 30 days after in situations when the orders for home health care for the patient are based on a new condition that the patient might be having. So if the physician wants to order home health for, say, an upcoming surgery, the surgery happens, we go in, you know, we can do a face-to-face encounter to verify the eligibility for home health after the start of care, but only up until 30 days. And then I went over that part. Okay. So, like we had said earlier, the face-to-face is a brief narrative composed by the certifying physician that describes how the patient's clinical condition, as seen during the encounter, supports the patient's homebound status and need for skilled services. So, just a statement that points to that. The certifying physician must document the encounter either on the certification which the physician assigned or a signed addendum. It is acceptable to dictate it to somebody and then sign it. However, you cannot dictate it to home health. It has to be somebody in your organization that you actually dictate it to. This is an example of the one that Essentia Home Health uses. My agency, we send this off as soon as possible, and we identify first the actual encounter before we send it off at Essentia to try to make things more smooth. It's a little hard to read what is said there, but ours reads, I certify that the patient, actually I can't even read it.
May I ask something?
Yes, sure.
Are these meaningful face-to-faces or just writing down and getting them out?
Basically, like I said, what CMS has done is they're trying to pull together that home health is actually being supervised by a physician. That home health isn't just going out there and doing things and just finding a doctor to put their signature down, which is a lot of time was happening, you know? And there wasn't as much doctor supervision and maybe accountability they thought there. So that's what the effort of this document is. Now, do you have to go into great detail when you answer these questions? No, it doesn't. It can be very simple. And I have actually an example of one here to give an idea. So yeah, I mean, they do have to be meaningful in that they have to be specific and unique to that individual.
And on both ends, not just.
Right, because then you know, you can make it specific to that individual, but then you have to show a need in that condition for home health. So understanding what home health does also has to come into play when you're filling out the face-to-face.
So practically speaking, for our residents who are going to be discharging patients from the hospital, so they had a cystectomy, big operation, they haven't been doing as well, we need home health to come by and see them. They need to write an order for home health, and they need to write either in that order or in the progress note the documentation of what's necessary, you know, why it's necessary, why they're considered to be homebound, and then fill
Actually,
Well,
no.
one of the things I just want to answer is that there's going to be a new, as of 2013, January, they're actually changing this, and yes, the documentation did have to be filled out as well, but now what they're going to allow is any of the discharge paperwork that answers those questions, like the reason the home health is needed, the diagnosis, and the home health status, but that's going to be significant enough for
So
us.
that, yeah, so if it's in the discharge summary or whatever, but still our physicians have to be actively involved in ordering this. It can't be just the nurses, the nursing stations saying, we need home health.
Right.
Let's put the paperwork in, and then 6 months later, I get a piece of paper to sign saying I agree with home health, which is the way it's happened in the past.
Right.
I mean, Tom and I and everybody gets, every attending physician, you guys probably don't know it because you don't get these things. So the attending physician, several months down the line, gets this piece of paper with all this writing on it from the home health nurse to sign and say you agree with it. So I guess this is an effort by ACA to make sure that these things are actually proactively done and declared for that.
I think, yeah, I think what you're experiencing is probably some non-proactive actions happening by the home health that's taking responsibility for that care that was done, since you're seeing it so far down the road. What you could also be running into is the fact that maybe another physician that's in the community that's seeing the patient, the home health thought that they were going to get it filled out by that physician, and now it's turning out that that physician, for whatever reason, has said no, which happens. And so they're going back to the trail to say, well, where did home health stem from? Oh, it stemmed from their hospital, their stay, where the urology, so that's, they're maybe trying to go backwards on that trail.
Unfortunately, it's not just in the private sector. The VA is one of the worst of these.
Well, you know what, on that side of it, we might have already submitted the paperwork months ago, and it's just getting to you.
I mean, it sometimes takes a long time to do.
Yeah.
But the bottom line of all this for the residents is that this has to be a proactive thing. It's not just something on the day of discharge you say, oh yeah, I'll work at home health. Because it's not gonna work. Either the home health guys are gonna come out and then they're not gonna have the documentation you need to be paid, which is not good for them. Or your life is gonna be made miserable trying to find paperwork retroactively and put it all in place. So it's better to think about these things and putting the appropriate documentation in order before the patient leaves.
Yeah, definitely a statement to this effect, formulating on the initial orders of discharge would take the place of anybody coming back and seeking this documentation to be filled out afterwards.
So we've also seen a bit of mission creep in the home health nurses' notes back to us. We send them off because they need home care or they need whatever. And then it comes back with a whole list of other things they've been doing, wanting me to sign off on that.
Right.
And so it's important also when you write that order or that note that you write what you want them to do. And if they want to do more, if they think a patient needs more, they'll call you back and they'll say, so-and-so, I think he needs this. Is that okay? And they'll document that and they'll send it back for you to sign.
The less specific you are, the more somebody else is going to interpret that. You know what I mean? So yeah, to be more specific is definitely better.
Some people are going to be very rigid about it. You only said I should do this, and some people are just going to put in everything they can possibly put in to get billing for it. So you have to be reasonably accurate in what your expectations are from the home health.
Yeah, and definitely, as far as an agency, Essentia, we'd be on the side of that. We'd come back to you if it was less specific. We'd be asking you, what about this, what about this? Trying to get more specificity. But other agencies will take the opposite direction, yes.
Can I ask you, Nick, also when you don't have the proper documentation from the doctor and your surveyors come in to survey you, then what happens?
We get fined, and our billing overall will get stopped. No matter what the patient is, we can get stopped altogether. Basically, it puts a really big wrench in things, and with this face-to-face document, it seems like there is a little stigma because you're actually formulating, why the patient needs these services. And so therefore, I think physicians feel like they're taking on responsibility then for those services. And in a way that is true. And I think, it's somewhat a good thing, though, too, because we do want to have physicians following everything that we're doing on home health. But with that said, when the state comes in, we need to have everything that we do then authorized by a physician, and not having this in place is a big problem. And what's so hard about it too, and why it keeps coming up, maybe you find people coming with this document, is because of the time-sensitive nature. And it has to be done on an actual, face-to-face encounter. So it has to be related to a date, not just signed for today. Any other questions? Okay, well, thank you.
Also,
Go ahead.
the STAR program for the HMOs, they have to have 5 stars, and so even the ancillary, the home health agencies and staff, if they don't do a good job, it affects their 5-star rating, and so they want that 5-star because then they get extra money, and so it's really important that you do your job so he can do his job, and then also the HMOs, they get their star ratings.
Yeah, and then the patient gets the care too. That's all it's good.
And before, private insurances weren't really requiring this document, it was really Medicare, but now most of them do follow the Medicare guidelines, so now a lot of them from Humana, Care Group, and Plus, they're all requiring this document now. So it is also an important part for the fact that if this document isn't received within a timely manner, the services for your patient are going to be stopped. So they're going to lose that because we don't have proper documentation to continue the services. So
That's accountability.
right, and we have to discharge them because we don't have a doctor that's willing to say these services are justifiable. So therefore, your patient, if they're in the middle of wound care or whatever it is, we cannot continue to be in there because we do not have that certification.
So there's like a 120-day window with the 90 and 30. If nobody's willing to do an encounter that happened during that time, then we can't continue. It's just we can't, because we don't have that
They
document.
do lose services, so the patients are definitely affected. Everybody's affected by it, so.
So bottom line is, if we want to continue to be able to send patients home and have home health, we have to make sure we got the paperwork done right.
Yes.
Especially if it's
So it is our responsibility. It's not just a piece of paperwork that's a pain in the rear to fill out.
also that, but yes.
Very good.
We only have one more section, sir, and I need that, and that's billing. Because if you're not billing correctly, or if you don't have a good billing company, then you're not gonna be able to pay your bills. And I looked online to see how much the average urologist makes, and it said like $216,000 on up. And I don't know if that's true, but I just wanted to tell you, if the billing is not done correctly, that's not what's gonna happen. And so we just have one little part about billing. Okay, but before you can bill, there's a 52-page application that you have to fill out to do Medicaid. And the checklist, there's a 2-page checklist of everything that you have to have completed with the TMHP in order to get the ability to do Medicaid, but it's 52 pages. Okay. So we're going to talk about billing, and then we'll have our conclusion. But I can't talk about billing without talking about waste, fraud, and waste, abuse, and fraud. And that's something that me, as an agent for the 25 insurance companies that I represent, we get tested on every single year. Waste is practices that spend carelessly and allow inefficient use of resources items. Abuse, practices that are inconsistent with the sound fiscal, business, or medical practices. that result in unnecessary program costs or reimbursement for services that are not medically necessary, and fraud, any act that constitutes fraud under applicable federal or state laws, and just knowingly just deceiving and sending out any kind of billing that is false. The most common types of waste, abuse, and fraud is billing for services not performed, billing for unnecessary services, upcoding, billing outpatient services as inpatient services, overtreating, and a lack of medical necessity. And in all honesty, you're going like, okay, so it's billing, but honestly, if you don't have a good billing company, or the office staff is not doing what they're supposed to do, first of all, you're not going to get paid, but if they upcode or if they do any of these things, it's going to come back on you, and you're the one that's going to go to jail. When you're billing for Medicaid, there's certain times that you're able to, if they have MQMB, that you can balance, what we call balance bill, meaning that if you agree to accept what Medicare allows, then if you have a client that has MQMB, you can actually, what we say, balance bill for those co-pays and those deductibles that you missed out on. If you not bill within a certain time frame, then you miss out on the money. So it's important that whoever you use for your billing, that I understand you got to deal with the patient care and everything, but it's also a business. So you have to make sure that they're billing correctly. If a claim is denied, you only have a certain amount of time, which is within 95 days, to appeal that claim. And if you don't do it, then therefore you could lose out on the monies that you're supposed to get for services. Providers accepting Medicare or Medicaid assignment cannot legally require the client to pay the Medicare co-insurance or deductible amounts. So no matter what they tell you, no matter what anybody's ever said, if you accept the assignment, that's what you're supposed to get paid. You can't make them pay it. Providers are encouraged to allow 60 days from the date of Medicare disposition for a claim to appear on the Medicaid remittance advice. Has anybody ever seen a remittance advice or an EOB? Do you know what an EOB is? No? It's the evidence, and we have it up here. It's the explanation of benefits. It shows why the claim was paid or it was denied. And they give you the reasoning so that you can make that correction and so that you can get paid. Prior authorization for wound care and supplies as of September the 28th. If you have a client that needs wound care because of whatever procedure you've done in them, it has to have prior authorization. That's one of the things, like I said, that you have to know about the insurance companies that you're working with, whether it's Medicaid or Medicare or one of the HMOs. A lot of them are requiring prior authorization. The Medicaid population includes the aged and people who have disabilities and chronic illnesses. The Texas Medicaid pays for long-term care, such as nursing homes, which we talked about, and also because of the unique concentration of medically high-risk persons enrolled in Texas Medicaid program, no commercial insurance pool would resemble the Medicaid population. When Governor Rick Perry was talking about wanting to, get out of the Medicaid program, and several people, the doctors, are saying that they don't want to accept Medicaid. What you have to realize is that if we opted out of the federal program about the full impact of loss that would happen, in 2009, we would have lost $15 billion in federal matching funds for client services in hospitals. At the same time, Texas residents and businesses would continue to pay federal taxes to support other states' Medicaid spending. So we would opt out of it. We wouldn't get any money, but we still have to pay our taxes, and our taxes would go to the other states for them, for their Medicaid program. Up to 2.6 million Texans could become uninsured. Hospitals would still be required by federal law to treat medical emergencies of uninsured former Medicaid and CHIP clients, potentially adding billions to uncompensated care costs each year. And it would be difficult for us to be able to keep the federal, the legislature could preserve benefits for some current Medicaid and CHIP clients using the state share funding while shielding the state budget from significant losses. But that would be difficult if we didn't have a cost sharing with the county government and the public hospitals. So we need Medicaid. I couldn't find an app for Medicaid for you. I tried. I looked everywhere, but I could find some other apps that's going to help you with some of the clients that you're going to see in your practice here in San Antonio. One is this assistive app that for those with disabilities, it's a great tool for anyone unable to use their voice. So when you deal with clients that have MHMR or they can't speak, this is an app that you can use. This app actually for those people that are when you're treating patients that speak a different language. I know that we talk about Spanish and English here in San Antonio, but we got a Hindu consumers. We have Vietnamese. And so then therefore there's an app for that. And then the last app is for those of you who don't speak Spanish. Uno, dos, tres, that's all I know, okay? So this app right here is good to help you when you're speaking with your Spanish-speaking clients here in San Antonio. So, did you receive anything about Medicaid that you didn't know? Probably, you know. Medicaid is Medicaid. But the thing of it is that just knowing that we need you to be a part of the Medicaid community, fill out the 52 pages, do the checklist, whatever you need to do, and then also remember that we expect each of you to impact the population that you serve. So good luck in all your endeavors as you navigate through the maze of Medicaid and Medicare. Thank you.